Hi, please can you hear me?
Yes,
we
please.
can hear you.
Yes,
Okay,
sir.
so this is the
Yes,
platform
sir.
that we're talking about, right?
Yes, sir, we
I
can
think
hear
I
you.
saw it somewhere. I just didn't read the message.
Go and pick it inside. Did you hear what I said?
Na mo cry, ya na dia astemni. Mo gwaro ma wo. Ah,
Please mute yourselves, please.
Yes,
All right, now because this is more or less like a third party kind of account, I will not be able to mute everybody together. So I need someone to be doing that for me. Probably the class rep can do that. Okay. Else, if I hear noises, I'll just keep talking, right? Whether you hear or you don't, then that's up to you. Okay, so let's continue from where we left off. All right. So we're saying that a drug is not going to work unless that drug is bound. So that drug needs to bind to something in the body before it can exert the effect that we need from that particular drug. Now, even though this may happen for most of the medications that we are going to see on the ward, it doesn't mean that every drug will have to identify a target in the body before that drug will be able to give any therapeutic effect. There are some exceptions to this rule. And typical example are the diuretics. So I was telling you that diuretics are used to manage hypervolemia. So any type of edema at all, you may want to use a diuretic. Now there are different classes of diuretics. You can talk of the thiazide diuretics such as benzofluazide. You can talk of the loop diuretics such as furosemide or Lasix. You can talk of the carbonic anhydrase inhibitors such as acetazolamide, and then some other diuretics that you can mention. Now, these diuretics that I talked about are all diuretics that can cause or can manage hypervolemia, but then they need to bind to a target in the body before they can do that. The thiazides need to bind to what we call the sodium chloride transporter before they can do that. The acetazolamide guys will have to bind to an enzyme known as the carbonic anhydrase before they can do that. But then there's one class of diuretic that does not require any target before they can exert an effect, and they are known as the osmotic diuretics. Typical example of an osmotic diuretic is a drug known as mannitol. If you give mannitol, mannitol can gain access to the nephron, then it sits within the nephron. Mannitol looks like sugar, but the difference between mannitol and glucose is that glucose can be metabolized by the body to ATP. So if you put glucose there, the body is going to metabolize it, use it for energy. But the mannitol behaves like glucose, just that you cannot convert mannitol to ATP. You cannot metabolize mannitol to ATP. The body will have to come up with other means before you can excrete mannitol. Now, sugar, just as you probably remember from your SHS days, when you have maybe a piece of yam, then cut some hole in it. You put sugar solution in it, then you put the whole system in water. You realize that you come back the next day and water has filled the entire compartment where you place the small amount of sugar. That is because water is moving using a force called osmosis. Okay, so the sugar is able to pull water to it by using osmosis. That's what these diuretics are going to do. If you put mannitol in the nephron, which is the functional unit of the kidney, because mannitol can exert an osmotic pressure, it can pull water from interstitial spaces and then from plasma as well onto itself, so that when it comes into the nephron, the person can pee that excess water out. So when someone is having dyspnea because of pulmonary edema, or when someone is having maybe pedal edema, then give the person mannitol. That person is going to lose the excess fluid in those areas through urine, because mannitol is going to pull that excess water onto itself whilst it is within the nephron. So it's able to manage hypervolemia, manage edema, but then it does not do that by binding to any target. It just uses osmosis to move water from spaces where there are excess then the individual can pee that out. There are other classes that can also use this same osmotic pressures to be able to exert an activity. I believe we all know the various infusions that we use in the hospital, right? There's normal saline, Wenger's lactate, dextrose in saline, D5, D10. At some point, we're even using D50 if you can get a central line. Now, the issue with these types of infusion, we call them the crystalloids, is that whichever volume that you administer, it is known that about 2/3 of that volume is going to leave the intravascular space and then accumulate in extravascular tissues. It could be the interstitial spaces. So when you give someone 600 mils of, say, normal saline, right? That 600 mils that you've given, only 200 mils will remain in blood. The 400 that is left is going to leave blood and then go to extravascular tissues or interstitial tissue. So when you have to do fluid replacement therapy for someone who is having a very huge fluid deficit, the person is having a deficit of maybe 2 liters that you need to replace with fluid. If you want to use normal saline, it means that you have to give 6 liters of normal saline so that 2 liters will remain and then 4 liters can escape outside the blood vessel. Now, in as much as that can reverse hypervolemia, you can be in severe trouble, in huge trouble when you do that, because the excess 4 liters that are escaping can go to the lungs and cause acute respiratory distress syndrome. They can escape to other parts of the body, such as the limbs, cause speed edema, etc. Okay, I quite met a patient who had an asaka because the person was infused with so much of these crystalloids. So when you have to do so much of fluid replacement, but then you cannot afford to lose so much to the extravascular spaces, then there's a class of infusion that you can do. Unlike the crystalloids, okay, these guys will stay in blood. They will stay in the intravascular space so that you are not going to lose any excess fluid out. And they are known as the colloids. So for infusions, you have 2 types, crystalloids and then colloids. Typical example of a colloid is albumin. You can also get mannitol as an example of a colloid. These guys, as I explained for the osmotic diuretics, behave just like simple sugars. They're able to pull water onto themselves, just that you cannot metabolize them to ATP or energy. So when someone is having a fluid deficit and I put inside that person 500 mils of albumin, what will happen? That 500 mils of albumin will stay in blood, and it will begin to pull water from other spaces, other interstitial spaces, other extravascular spaces into the intravascular space. So I place there 500 mils. Eventually, I'm going to end up getting more than 500 mils. I will get about maybe 1.5 liters. Where is that excess 1 liter coming from? It is your albumin or mannitol using osmosis to pull water from all these excess spaces into the blood so that it can combat hypovolemia. Okay. Now let's say that someone is involved in a road traffic accident. Please, can we mute ourselves? Okay. When someone is involved in a road traffic accident and the person has lost a lot of blood, you are only allowed to give a certain
Yvonne
amount
Labi,
of blood.
please mute.
The rest of the volume, you may have to make up that excess by using your infusions. Okay. Another situation, let's say that the same person was involved in an RTA, and the person hit his or her head against the seat in front of him or against something. When in that traumatic event, the brain will begin to swell. Inflammation will begin to happen in the brain. And one thing that accompanies inflammation is edema. So what you can do is that the neurosurgeons can sometimes go in. Please can you mute ourselves? There's this noise that is really, yes, thank you. What the neurosurgeons can do is that sometimes they can just go in, take a portion of the skull off so that the brain will get enough room to swell, expand. Then when the inflammation is over, it can come back to its size again. That is one thing that you can do. One thing that you can do to help this event, or sometimes even replace the entire surgery with this, is that you can give the person albumin as an infusion. When you put albumin in the blood, right, around the brain, there are blood vessels, okay, so that blood-brain barrier. it is permeable to water. So the albumin will be in the intravascular space. Because albumin has that osmotic effect, it can pull water onto itself. It will begin to pull water from the brain. So the excess fluid that is accumulating in the brain, that edema that is having in the brain or is occurring in the brain, albumin can pull the excess water out of the brain into the blood. Then you can lose that excess fluid to other compartments, right, to enhance elimination. So you can use albumin to prevent the brain from swelling when someone is involved in a traumatic brain injury. Okay, so it is able to reverse this effect, not necessarily by binding to a target, but then by just using osmosis to move water from spaces that you don't need it to spaces where you can easily eliminate it. Please, any questions so far before I move on to the rest?
Hello, sir.
Yes, please, I'm listening.
With all respect, sir, you are going too fast. We are lost.
I'm still
Majority of
fast.
us,
Very fast.
yes, majority of us are lost. We don't even know where we are going now. Please.
Yes,
I'll
so
slow down.
me, for instance.
I don't even know what to do.
That's true, please.
Please, what
Me
you are saying is
too.
not on my screen.
Please,
Sir,
what
we don't
screen are you
we
seeing?
can't see your screen. No.
We are not seeing your screen.
Please, can you talk one at a
Guys,
time so that I can listen?
I don't even know where
we
we
are
started
lost.
from. Where we
He's saying
getting
talk one at a time.
Please.
All right, so let me continue since I cannot hear anybody. All right, I'm going to slow down. Before I
Yes,
agree
sir.
that if you give a drug, the drug has to bind to a target in the body before it can elicit an effect. Please, do you all agree with me on that?
Yes, sir.
Yes, sir.
Yes, sir.
And I'm saying that even though this is the case for most of the drugs, it is not every drug that needs to identify a target in the body before that drug can give an effect. And I was given examples as a drug called mannitol. Mannitol is an example of an osmotic diuretic. Osmotic diuretics can cause or enhance urination by not binding to any target in the body. All that they do is that they use osmosis to move water from places in the body into the nephron or the kidney, increase the urine volume so that the individual can pass urine. That is all that they are doing. Okay. And I also gave example as colloids. Colloids are intravenous infusions that we give. Unlike normal saline and all those guys, what they do is that they just stay in blood, then begin to pull water from other interstitial spaces, extravascular spaces into the blood so that you can increase the blood volume and prevent hypovolemia. So that's the colloids. Please, are we okay with that?
Yes, please.
All right.
Yes, sir.
Hello, say.
Please, what you are saying is not showing on my screen.
Hello, say.
Please, what screen are you seeing?
Hello, say.
Yes, please, I'm listening.
Sir, please, can you mute us? The noise at the background is just too much. Please.
Yes.
Lisa,
Unfortunately,
Lisa, hello, Lisa.
please let me answer
Is
her before you come in, okay? I
okay,
cannot
sir.
mute with a primary account. I could mute everybody, but this is a secondary account. Myself, I'm a participant on this account, so I cannot mute anyone like all of you at once, unless I have to more or less go through to identify whose microphone is off on before I can do that. That's why I
Hello,
asked someone to help me out. Please, are you okay?
hello, sir. Hello, sir.
All right. Yes, please, I'm listening.
Please, sir, the class is interesting, but you are a little bit fast, and your screen is not sharing on some of our screens. Please, if you can do something about it. But it's interesting. I'm enjoying the class well, but it's very fast.
Others can see the screen, so please, if you cannot see, kindly check your network.
Okay,
Please,
sir. Okay,
can
thank you,
anybody
sir.
see my screen?
What you are
If you
saying
all
is
cannot
not
see,
showing on the screen.
Not
No,
showing on
sir,
their
we can't
screen.
see anything.
please, what screen can you see?
What I can see here is corpora non-urgent.
Exactly. So that is where I am.
That is all, sir. With a picture of an old man.
Yes. So that is the slide that I am on.
But we
Please, are
have
you
not
okay?
seen what you are reading, please, sir.
Please, can you see osmotic diuretics there?
You can see osmotic
Yes,
diuretic,
sir.
osmotic
And I'm just that's
negative,
all.
tacit, and heavy.
Okay.
On the screen.
All right. Now let me say this before I continue. Okay. Please, let me pause all the questions until after 15 minutes, right? After 15 minutes, if you have any question, you can ask. Else you are not going to go anywhere. All right. What I want to say is that, at this point, I cannot feed you with everything. So there are a lot of things that I'm going to say that are not on the slide. If I want to put everything there, then I need to give you a pamphlet, okay, or a textbook to go and read. So most of these things, I'm going to say it to explain what is on the slide. The explanation may not be there. For some of it, it may be there. That's why we are here. I'm recording it too. So I can always give it back to you, then go back and then you listen. Please, are you fine with that?
Yes, sir.
Thank
Yes,
you very much.
please.
Now let's continue. I'm going to do my best to slow down as much as possible. Okay. All right. Please, can we mute ourselves? There's this noise that is really disturbing. Okay.
Who is that?
Jennifer, please mute yourself.
All right. Thank you. Now, aside osmotic diuretics,
Let's see the screen. Your typing is distracting us.
aside the osmotic diuretics and then the osmotic purgatives, other classes of drugs, such as antacids, can also work and give an effect without having to bind to any target in the body.
Okay.
Now, an example of an antacid is aluminium hydroxide, what you often call aludrox. Okay, you can talk of magnesium trisilicate, sodium citrate, etc. Okay, all these are antacids. Antacids are basically drugs that are anti-acids. So if you're having hyperacidity, you're having dyspepsia, heartburn.
Please keep quiet.
Because you've taken maybe some acidic food, you've eaten kinky, eaten wachi, you are having a lot of acid production. So there's this reflux effect that is getting the acid to maybe the esophagus, causing you to have this heartburns. You want it to go away. So in this case, you want to treat dyspepsia. What do? You take an antacid. Then the antacid is going to give you a relief from this dyspepsia or this heartburn. How is the antacid able to do that? It does not bind to any target. What the antacid does is that antacids are basic, they are alkaline. So when they come into contact with an acid, they just neutralize the acid. So it's a chemical reaction. The antacid will just neutralize the acid, convert it to water and then a salt so that you get your relief. It doesn't bind to any target. That is how antacids are able to give their activity against hyperacidity. One other class that does not require a target before it can give a therapeutic effect are the heavy metal chelators. These are drugs that you use when someone is being poisoned with a heavy metal. An example of a heavy metal is lead.
Odroyeboa, please mute yourself.
Odroyeboa is your lecturer, okay? All right. That's good. Okay, so yes, that's me. My name is Kofi Odroyeboa. Okay.
Sister, relax.
It's rather Madam Lydia. It's Lydia who is making the noise.
All
Madam
right, that's
Lydia.
fine. Let's continue. Okay.
Sir.
That's all that will happen. If you don't meet ourselves, that's what will happen. Okay. Now, because of regulation nowadays, you don't get a lot of pains that contains lead. Okay, I don't know how old you are, but I'm very old. When I was a young man, okay, we used to use these paints on buildings, and those paints contain lead. Okay, now some of the children will just go and sit by these buildings and then scrape off the paintings to play with them,
Hello,
or
sir.
sometimes to even eat it as if they are eating
Hello,
chalk. Yes,
sir.
please, I'm listening.
Sir, please, can you increase your voice a little for us, please?
Yes, please. In fact, I am shouting at the
Thank
top
you.
of my voice. Okay. So I think the network will also play a part in this. All right. Okay, so what I was saying is that some of these children were eating the paints, and because it was containing lead, all right, lead becomes available in very high concentrations in the body. That is not supposed to happen. If it happens as such, it causes toxicity, lead toxicity, and it leads to a condition that I call plumbism. Okay, plumbism. It's some form of neurotoxicity. Now, if you don't manage the condition, it's going to lead to coma, and then the person can die out of that. You don't want that to happen. So there are medications that when someone is having lead toxicity, you can give. One example of such a medication is called EDTA. EDTA, the full name is ethylene diamine tetraacetic acid. I believe you've heard of it before. One other drug is also known as dimercaprol. Okay, dimercaprol, dimercaprol, dimercaprol. Now, when you give these medications, they are able to manage or treat against lead toxicity. How are they able to do that? When you give them and then they go into the body, they begin to scavenge for wherever lead is. So they go into the body, then they begin to look for lead. Once they find lead, they physically bind to lead and then complex with it. They chelate lead. They decide to make lead not available to go and cause toxicity. When lead is free, sometimes it can trick the body into picking it instead of calcium. It can trick the body into picking it instead of any other divalent cation. That's how it causes problems in the body. So these drugs will go into the body, find wherever lead is, bind to lead so that lead will not be free to go and cause the harm that is supposed to cause. So in this case, if you give the person dimercaprol or EDT, it begins to reverse the lead toxicity. The person begins to get better. It's not because your EDT or dimercaprol is binding to any target in the body, but then all that is doing is that it has caught lead and has prevented lead from going to cause any further harm. With time, your body will be able to eliminate your EDT and then the lead complex, or the dimercaprol and the lead complex. It does not bind to any target. It just finds the guy causing the problem, catch that guy, and then the body can eliminate it. One other heavy metal chelator that you can also use is a drug known as deferoxamine or desferoxamine. Either of it is right. When someone has been infused with so much of blood, or the person has taken excess hematinic, iron becomes available in excess in the body. If care is not taken, it can cause a condition known as hemochromatosis or hemosiderosis. That both of them is not something that is good that we should entertain. So in that case, you give the person a medication that will prevent the body from utilizing iron. And that medication is called deferoxamine or desferoxamine. You go into the body, it will catch iron and prevent iron from becoming available for use by the body. So it's going to chemically complex iron or chemically chelate iron. So they do not need any target. They just prevent the iron from becoming available. There are some few other classes that will be able to exert their therapeutic effect without having to bind to any target in the body. But these are the few ones that I would like you to know. So summarizing this slide, a drug is not going to work unless the drug is bound to something, a protein in the body. But that is not always the case. Sometimes there are some few drugs that will be able to exert an activity without having to bind to these proteins. And typical example is an osmotic diuretic. Example is mannitol. Another example is a colloid, which mannitol can also become an example. Albumin is also an example of a colloid. Another example is the antacid. Example is aluminum hydroxide, sodium citrate, magnesium trisilicate, etc. Then you also have the heavy metal chelators such as diferoxamine, dimercaprol, and then EDT. Okay, all these guys are there. There's one class that I did not talk about, the osmotic purgatives. Purgatives are also laxatives. Okay, they are just enhanced laxative, if I should put it that way. A laxative is a drug that when you take is able to cause diarrhea and enhance defecation. Okay, there are several types several classes of laxatives, the bulk forming laxatives, stimulant laxatives, etc. There's one particular class of laxative called the osmotic laxatives or osmotic purgatives. They are the same. Okay, these guys are able to cause diarrhea or relieve constipation by not binding to any target. All that they do is that they sit in the gastrointestinal tract, move water from other spaces into the GIT, so that when there's excess water there, the fecal matter can become soft, it can become lubricated, so that it can easily excrete it out of the body. So that's all that they do. An example of an osmotic purgative is a drug called lactulose. Okay, lactulose is an example of an osmotic purgative. So these are drugs that when you administer can work without having to bind to any. Please, any questions so far before I move on?
Yes, sir. Sir, please, I have a question.
Yes, please, I'm listening.
Please, when you were talking about the heavy metal chelating agents, I don't know, it's like I didn't hear you well. You mentioned a word, is it ADT or
EDTA.
EDT?
EDTA, ethylene diamine tetraacetic acid.
EDTA, okay, thank you.
Yes, please. That is what you find in the Bakitena tubes. When you draw peripheral blood, okay, when you want to take blood for, let's say, full blood count, that tubes that you put in, okay, some contains EDTA, some contains citrate, etc. That's the EDTA that I'm talking about.
Okay, thank you, sir.
You're welcome.
Hello,
Please, any
sir.
other question? Yes, please.
Sir, please, what did you say the example of the osmotic purgative was? I didn't hear you.
Lactulose.
Oh, okay, thank you.
Yes. So lactulose is used
Hello,
to
sir.
cause or treat constipation.
Hello,
We
sir.
also use it in patients with hepatic encephalopathy to prevent them from developing the condition. Those with end-stage liver disease, you give it to them, it causes diarrhea. There's not a buildup of nitrogenous bases in the stomach or in the gut, so you don't form ammonia, and ammonia does not go or do not cause any encephalopathy in such patients. So that's one indication for them. Okay, that's lactulose. Please, any other question?
Hello, sir.
Yes, please.
Yes, sir. Sir, please, you said the osmotic laxative or the purgative, they don't combine with anything, but they do something. I didn't hear that part well, please.
Okay. I said that they can cause or they can relieve constipation. You take it when you're having constipation. So they can cause this effect without having to bind to any target. All that they do is that they are able to cause the person to have diarrhea by moving excess water into the GIT. So if you have a lot of water in your stomach, then automatically what happens is diarrhea. It lubricates the fecal matter, then it makes it soft as well, so that the person can easily go to the washroom. That's why when someone is having constipation, you can give them. Please, are you okay?
Yes, sir. Thank you.
Okay, I believe we can move on. Now that we've identified that drugs will have to bind to targets before they can work, even though there are some exceptions, let's look at the ones that can or have to identify or bind to targets before they can work. Now, these targets, what are they? There are millions of them. Okay, several targets in the body that drugs can interact with. But then we can essentially group or classify these targets into basically four main targets that drugs can interact with. The first ones that we are going to spend some time on are the pharmacological receptors. They are also known as physiological receptors. There are several examples. We will look at them very soon. Then you have the voltage-gated ion channels as well. There are different types of ion channels, but principally we are talking about is the voltage-gated ion channel. Then there are some enzymes that can also serve as targets that drugs may have to identify, bind to them before they can exert their activity. I'll give you several examples. One example is aspirin. Aspirin identifies an enzyme in the body called cyclooxygenase. Block that enzyme before you can get an anti-inflammatory effect or an analgesic effect out of that aspirin. Okay. Then you also have other targets such as transporters or carrier molecules. And essentially, some of the diuretics that you have available will have to bind to these transporters, like Lasix. Lasix is furosemide. It identifies a sodium chloride transporter before it can exert its diuretic effect. So we later pick time or look at pick each one of these and then go into much detail. I'll not bore you so much with the details of this. I'll just give you some slight information that you'll be able to, it can help you understand some of these drugs that you use in the clinic. So let's pick the first one, pharmacological receptors. Essentially, these guys are physiological receptors. When I say physiological receptors, if you have a cell, the mammalian cell or the eukaryotic cell is made up of different parts. Okay. Essentially, you have these whole components being housed in a cell membrane. The mammalian cell has a cell membrane and it's a phospholipid bilayer. Okay. On the cell membrane, you can have a whole lot of proteins. Let me see if I have, yes, let's look at this diagram. This is a cell membrane, right? This is the intracellular space, the portion that exists within the cell. Okay, this is the extracellular space. Now, this is your cell membrane. The cell membrane is made up of a phospholipid bilayer. So you can see the phospholipids there. Now, as part of this cell membrane, you can have some proteins there. And those proteins may serve different functions. Some of the proteins are there so that some moieties can recognize them and then bind to it. Let me give you one specific example. There's this cell called the CD4 lymphocyte. Okay. The CD4 lymphocyte has a protein on its membrane called the CD4 antigen. That protein, all that it does is that this has several uses. But then there's this particular pathogen, the HIV. Okay. HIV is able to identify the CD4 cell, but not any other cell because it has that specific protein, CD4 antigen, in its cell membrane. It can identify it and then bind to it so that the virus can gain access into the cell. That is one type of protein that you may have on the cell membrane. But then there are other types of protein on the cell membrane that what they do is that they are able to recognize certain soluble physiological mediators. So naturally, the body produces certain chemicals. These could be hormones. These could be neurotransmitters. Okay.
What
An
kind of life?
example of a hormone is estrogen, testosterone, etc. It could also be neurotransmitters such as acetylcholine or adrenaline or noradrenaline or serotonin. These are all soluble physiological mediators. These are compounds, chemicals that the body naturally produces. Okay. Now you may have a protein on the cell membrane that can recognize these soluble mediators. Okay. When these soluble mediators bind to those proteins, they are able to change the way that the cell behaves. So let's say that the cell is involved.
But who is that misbehaving? If you are not interested, just go off and we'll continue.
Let's get away. Let us continue. What
Can
is
you
that?
be at lectures and be singing and be...
Okay. Let's say that the cell that is of interest is a cell that is involved in movement. So naturally, the cell controls movement. In the absence of anything, right, the cell is, let's say, moving faster or it enhances faster movement. That is what the cell does. There are these proteins located on the cell membrane. Sometimes they can be within the cell. That certain soluble physiological mediators, they could be hormones or they could be neurotransmitters, as I mentioned. When they bind to this protein, they are able to change the way that the cell is able to regulate the movement. So when these soluble mediators bound to this specific protein, it is able to slow down the cell, or it is able to let the cell control movement at a faster rate. Either ways, it has been able to change the normal physiology of the cell. What we are saying is that if you have such a protein on the cell membrane or within the cell, that when these mediators bind to, they can change the way that the cell is behaving, then we term that particular protein as a physiological receptor. That protein is known as a physiological receptor. But then, if you look at something like adrenaline, noradrenaline, okay, instead of waiting for the body to produce its own, sometimes you can supply it as a drug or as a medicine, an exogenous compound. Now, because you can give these things from outside the cell or outside the body, and then they can still go into the body and bind to this same receptor to change the nature in which the cell is behaving. We can also term that protein as a pharmacological receptor. So any protein located on the cell membrane or within the cell that can respond or recognize certain compounds that is being administered into the body, or certain compounds that the body is producing naturally, in the sense that when those compounds bound to that protein, it can change the way that cell is behaving. Then we can term that particular protein as a pharmacological receptor. Please, are you okay with that?
Yes, please.
Okay. Now let's go back. So that's the pharmacological receptor. It operates under what you call a lock and key mechanism. Okay. It is different from other targets in the body because you need to have a certain shape, a certain size, a certain nature before you can bind to a certain receptor. Unlike other targets that may decide to bind to drugs as and when they want to bind to them. For instance, when you start talking about distribution with Dr. Obrikwa, you come across two major proteins, albumin and then alpha-1 acid glycoprotein. They are found in blood. They help with the transport of or the distribution of drugs in blood. When you give drug, they will bind to these proteins and then it will carry them along. These proteins have less specificity for drugs. Once you're a drug, you're a weak acid, you're a weak base, you can bind to them and then they will transport you. They are different from pharmacological receptors in the sense that for pharmacological receptors, they're a little bit distinct. They bind to some drugs, they don't bind to the other drugs. It's either you fit on the receptor or you don't fit. So they're able to discriminate between compounds or discriminate between chemicals, and that's what makes them a little bit different. Now, a drug that is able to bind to the receptor, change the receptor such that it can activate the receptor and activate the cell that is of interest. That drug is known as an agonist. So if I give adrenaline because someone's heart has failed to beat and I want to restart it, so I give adrenaline. Adrenaline will have to bind to a certain receptor on the heart, the beta-1 receptor. Once it binds to that receptor, it can then restart the heart. Because adrenaline is able to do that, I term it as an agonist. But then there are some drugs that when you administer, they can bind to the receptor, all right, but then they cannot stimulate the cell, or they cannot stimulate the receptor. These guys are known as antagonists. Typical example is a drug called propranolol or bisoprolol, which I believe you've heard of these things before. They are antihypertensives. What do? They identify the receptor on the heart, the beta-1 receptor, and then they just go and sit on top of the receptor, bind to it, so that when adrenaline comes, adrenaline will not be able to come and bind to the receptor to cause the heart to beat. In this case, they're able to depress my cardiac function, and that's how come they're able to reduce the blood pressure. They're able to slow down cardiac activity. So some drugs can identify receptors, bind to them, activate them. Such a drug is known as an agonist. Some drugs are given so that they don't activate the receptor, but instead they sit on the receptor and prevent the true agonist from coming to stimulate. Such a drug is known as an antagonist. So with time, we are going to pick these two drugs and then look at them carefully. But then for now, what we need to know is that there's a target in the body known as a pharmacological receptor that when drugs bind to, they can elicit an activity or cause an effect to happen in the body. Now, if you pick this pharmacological receptor, there are different types of pharmacological receptors. The first type that I'll talk about is known as an inotropic receptor. An inotropic receptor is also called a ligand-gated ion channel. Later on, I'll explain to you why it is called the ligand-gated ion channel. Inotropic receptor or a ligand-gated ion channel. Typical example of a ligand-gated ion channel is the receptor that diazepam binds to. I believe you know what diazepam is and what it is used for. So the receptor that diazepam, lorazepam, etc. binds to is an ion channel, okay, a ligand-gated ion channel. Specifically, that receptor is called the GABA A receptor. GABA is gamma amino butyric acid receptor, the GABA A receptor. Interestingly, this is the same receptor that phenobarbital or pentobarbital, thiopentone also, and we'll be able to get the idea why sometimes you may have to give diazepam to manage convulsions, and then why sometimes if that fails, you may have to go to phenobarbital to also manage convulsions. It all borders on how they interact with this receptor, the GABA A receptor. There are other types of ion channels that we later talk about. The nicotinic acetylcholine receptor is an example of an ion channel, a ligand-gated ion channel. Now, the next type of receptor is called a metabotropic receptor, also known as a G protein coupled receptor. Sylvia, you have a question.
Please, so none of the GABA A receptor again.
Please, I didn't hear you. Can you come again?
Please, the full meaning of the GABA A receptor.
Gamma amino butyric acid.
Gamma amino.
So gamma amino butyric acid. If I change my cursor to a pen I want to write, I will not finish today. That's why I did not write. Okay, but I know you can find them. Otherwise, these things are it's somewhere within the notes. Okay, you definitely come across it. Okay. The next type of receptor, pharmacological. Yes, please.
Oh, sir, the class, the topic is very interesting, but the way you are moving, say, seriously, we are not getting anything. Yes.
I'm going fast.
Yes, you're too fast, sir. Please.
Like
okay, I'll slow down. But you notice that I spent about 15 minutes on one slide. That shows how slow I'm going. But either way, I'll slow down further, okay, to your level so that I'll be able to get it. Okay. All right.
Lisa, there are some technical words inside. That's why, but it's interesting. It's interesting, sir. But the technical
it's your first time doing pharmacodynamics, so definitely there will be some bit of confusion. But you later, by the time I'm done, you'll be able you'll be fine. We'll be at the same level. Okay, we are all going to be colleagues by the time we are done. Please, are you okay? So don't be scared at all. No, I will not lie to you. Okay, don't be scared at all. Right. Yes, that's why I said I'm not going to bore you with the details. There's a lot into this, but I've taken all of those things away. And then we are just going to look at how we can just simply apply some of these things to better understand drugs. Okay. Yes. So please, don't be scared about whatever that we are discussing. They are very simple. I'll later be showing you diagrams that can help you understand this. Okay. This is more or less like an overview of what we are going to do. Okay. All right. Aside the ion channels, there's another type of receptor called the G protein coupled receptors. G protein coupled receptors are also known as metabotropic receptors. Typical example is the receptor that adrenaline binds to. Please, I hope you all know adrenaline.
Yes, please.
And we all know morphine, right?
Yes, please.
So the receptor that adrenaline binds to is an example of a G protein coupled receptor. The receptor that morphine, tramadol, pethidine, fentanyl, etc. All these guys bind to are also G protein coupled receptors. The mu opioid receptor. We later pick them, talk about them. Okay. Now, most of the drugs that will be coming across in the clinic most likely will be working on G protein coupled receptors. So we need to, when we get into the bits of the signal transduction, you have to pay attention. Okay. The whole purpose is identify some of these targets so that when you are using drugs together, especially when you are doing polypharmacy or when you're using 2 or more drugs, you don't inadvertently use a drug that will block the activity of the other drug, because it happens. Okay. Last year there was this case that I came across. This lady had she had an abortion. She attempted an abortion. Okay, the fetus died, but then it did not come out. So as you are midwives, you know that in that case you have to do induction. All right, it doesn't make sense to go and do CS if the patient is not at risk. So they have to do induction. And by doing induction, this patient was also at risk of developing eclampsia because she had a pre-eclampsia. So they were giving oxytocin together with doing all those strategies that they do for pre-eclampsia, giving max of prophylaxis, giving the fedipine for the management of hypertension. Eventually, the lady couldn't pass the fetus out. She couldn't give birth, and they didn't understand why. They didn't know that they were using drugs that were counteracting the effect of each other. That's why the patient had to be on the ward for about 5 days before they could figure out what to do. So the whole purpose is to expose us to some of these things so that we'll be able to rightly apply drugs and not cause unnecessary harm or delays to our patients. Okay. We later look at the kinase-linked or enzyme-linked receptors as well. These receptors are receptors that their activity is linked to the activation of an enzyme. And there are different types of enzymes. Specifically, the enzyme of interest is called a kinase. A kinase is an enzyme that is involved in phosphorylation of proteins. In the body, if you want to activate any protein, you have to phosphorylate it. And the enzyme that does that is called a kinase. So these receptors are linked to the activation of a kinase that will eventually cause the activation of certain proteins in the body. We later look at them. Examples of a kinase-linked receptor is the cytokine receptor. When someone is having inflammation and the body produces so much of cytokines, how the cytokines are able to help foster the inflammation is because they work on receptors that are linked to these enzymes. Okay. The same way when someone is involved, has been exposed to a virus, and the body wants to protect the body from becoming infected by the virus and produce these cytokines, right? They are able to act on some of these receptors and then be able to protect the body. So they can do harm, they can do good, depending on the amount and then what exactly that they are doing. One other receptor that can also be said to be a kinase-linked receptor is the receptor for growth factor. Growth factor receptor is an example of a kinase-linked receptor. Now, the first 3 receptors that we've talked about, ion channels, G protein coupled receptors, kinase-linked receptors, all these are known as membrane-bound receptors. They are receptors that are located on the cell membrane, either on top of it or they exist as a transmembrane protein. They pass along the entirety of the cell membrane. They are docked to the cell membrane. But then the last type of receptor here, the intracellular receptor, is not a membrane-bound receptor. This is a receptor that is found within the cell. Now, within the cell, there are 2 possible places that you can get it. When you are within the cell, it's either you are in the cytoplasm, called the cytosol, or you are in the nucleus. So you can get a receptor that is within the cytoplasm. Such a receptor is called a cytosolic receptor. And typical example is the receptor that testosterone binds to, or dihydrotestosterone binds to, the androgen receptor, the receptor that is involved in benign prostatic hyperplasia or prostate enlargement and also in prostate cancer. It's an example of a cytosolic receptor. Then there's another receptor. This one is not within the cytoplasm. It is within the nucleus and is known as a nuclear receptor. Typical example of a nuclear receptor is the receptor that estrogen binds to, the principal female hormone. Okay, the receptor that it binds to is a nuclear receptor. It means that when estrogen is being produced by the body, before it can get any effect from estrogen, it first needs to go into the cell. Inside the cell, it has to enter the nucleus. It is within the nucleus that the receptor for estrogen is. But for testosterone, once it enters the cytoplasm, its receptor is there, and then it can just stimulate and cause an effect to happen. There's this drug called prednisolone. Have you heard of prednisolone before?
Yes, sir.
Okay. Prednisolone behaves like testosterone. Okay. So the receptor for prednisolone is within the cytoplasm as well. So when someone is having inflammation or anaphylaxis, right, then you administer prednisolone or you give it for any other off-label indication. All that you are doing is that prednisolone will first have to gain access into the cell. Once it enters the cell, its receptor is there. It binds to the receptor, then a whole lot of events will happen before you finally get the effect that you are expecting. Now, we've said that there are different types of targets. We mentioned 4 major targets. This is a summary. You said you have pharmacological receptors, you have enzymes, you have carrier proteins and transporters, and then you talked about the voltage-gated ion channels as well as examples of targets. Then under the pharmacological receptor, you've mentioned 4 main types of pharmacological receptors. The ligand-gated ion channels, also known as inotropic receptors, the metabotropic receptors, also known as the G protein coupled receptors. We talked about the cytokine receptors, which is an example of the kinase link or the enzyme link receptors. Then we looked at the final one, which is the intracellular receptors. Intracellular receptors, we said that it could be cytosolic receptors such as androgen receptors, or it could be nuclear receptors such as the estrogen receptor. Now, that being said, to prevent confusion, now that I've been able to expose you, for you to appreciate that there are a lot of targets in the body that your drug can interact with, I want to represent all those targets with the word receptor. So whether I'm talking about pharmacological receptors, enzymes, transporters, carrier molecules, voltage-gated ion channels, I want to represent all those terms by using the term receptor so that it will avoid any further confusion. Okay, so from henceforth, I'm going to use the word receptor to help us better understand things. Now let's go into each of these pharmacological receptors and then better glean an understanding from them. Before I continue, any question? What I did was an overview. Now I'm going to go over again. Please, any question? Okay, I'm glad you understand. Now let's pick the ion channels and look at them. Okay. The first type of pharmacological receptor, the ligand-gated ion channels. Why do we call them ligand-gated ion channels? Let's start from the word ion channel. This is a membrane-bound receptor. So what you see here is the cell membrane. Okay, all these things.
Please, the typewriters. Can you stop typing so that we can see the screen very well?
That's the phospholipid bilayer. Okay, one is here, one is there. Now, a channel is any passage that can allow for the movement of certain entities. So if you have a channel that allows for water to move, it is called a water channel or an aquapore. Okay, a water channel. The channel allows for water to move. Now let's bear in mind that these channels are proteins that are located on the cell. Okay, they are more or less, let's assume that the cell is a room. To gain access into the room, that's the intracellular portion of the cell, you need to pass through a gate. That gate is your channel. All right, that's the channel that we are going to talk about. Now, this channel doesn't allow any other thing to move into or out of the cell. What it allows to move into or out of the cell are ions, okay, such as sodium ion, potassium ion, chloride ion, etc. Once we have this channel allowing the movement of ion, it is called an ion channel. So the door inside the cell, that specific door allows only ions to go into or out of the cell. That is why we term that as an ion channel. Okay, please do get why we call it an ion channel before I move on.
No, sir.
No, sir.
Yes,
No, please.
yes, sir.
We allow ions to
Sir,
enter.
please, no.
Okay.
No,
No,
please.
please. Go
So for
over.
those of us saying no, this is what I want to say, even though I know that you mean yes. This is a cell. Okay. This is the cell membrane, the phospholipid bilayer. Let's assume that this is a room. Now, before you can gain access into the cell, let's say that this thing is outside. Okay, this is an ion, such as sodium ion. Okay, this is sodium ion. Please, can we mute ourselves? This is sodium ion.
Ah,
Please,
ah,
disturbing with your baby.
who is that? Who is that? Ah, ah.
Please, we are
Okay,
suffering to understand. So mute yourself.
this is sodium ion. This is the cell. Okay, now this is my nucleus. All right. Before this guy can gain access into the cell, right, before it can come into the cell, it has to pass through a door. Now, this is the door that I'm talking about. Okay. That door is a channel, right? Now, because that door is allowing for the movement of sodium ion, only ions into this cell, we are terming that as an ion channel. It is a door that only ions move through. Okay. It doesn't allow any other thing to go through unless you are an ion. That is why we call it an ion channel. Please, are you okay with that?
Yes, sir.
Yes.
Yes,
I'm
sir.
glad you are okay. Now let's come to the other aspect of the ion channels. There are different types of ion channels based on how the door opens. So the key that opens that door, that channel for the ion to move, that brings about the type of ion channel. So when talking about a ligand-gated ion channel, what we are trying to mean or imply is that a ligand can basically be a compound. So you can replace this with a compound or a chemical or a drug. Okay. It tells you that for this particular or for this specific ion channel, it only opens if a certain chemical, a certain compound, or a certain drug binds to that channel. So the only key that can cause the channel to open for ions to move in is a drug or a chemical or a compound. That is why it is called a ligand-gated ion channel. It is an ion channel that is gated by a ligand, that is gated by a drug or a chemical. So when you've not given the chemical, that channel is not going to open to allow ions to move. But the moment you introduce that chemical or that medicine or that drug, the channel opens and allows certain compound or certain ions to move either into the cell or out of the cell. Now let's focus on this diagram, the figure E, and let's try to see if we can use it to understand what you are saying. This is an example of a ligand-gated ion channel. What is the channel that we are talking about? This is the channel, this protein that you see here, okay? That's the channel. There is one part, that is one part. It forms something that looks like a pipe, a pore. And within it, we can have substances moving in and then out of the cell. Now, for this particular channel, it allows sodium to go into the cell. So these are sodium ions. We realize that sodium ions are coming into the cell. It can also allow potassium ions to go out of the cell, the same way that sodium is coming in. So when sodium is coming, it allows potassium to also go out of the cell. Sodium ion, potassium ion, all of them are ion channels. So we term this specific channel as an ion channel because it allows for the movement of sodium into the cell, potassium out of the cell. Now, how is this channel able to open? This channel will only open to allow the sodium to move in, potassium to go out, only when a specific ligand, a specific chemical, a specific drug called glutamate binds or glutamic acid. So when this glutamate binds, okay, then it is able to help the sodium and then the potassium to move. The glutamate binds, it opens the channel, it opens the door to the cell so that these guys can either move into the cell or move out of the cell. So this specific channel is known as an ion channel because, or a ligand-gated ion channel because it only opens to allow certain ions to either move into the cell or out of the cell, only when the ligand glutamate binds to the channel protein. Please, are you okay?
Yes.
Yes, sir.
Thank you very much. Now, an example of this receptor, I'm going to give you one drug that works on this receptor. As you are sitting there, your brains are working because your brain is producing glutamate. Glutamate binds to this receptor, sodium is able to move, potassium is able to move, then it's able to help you become alert. You're able to process information. There's neurotransmission happening because glutamate is being produced. But then, if I don't want the brain to work, such as maybe I'm going to do surgery, I'm going to cut the person, there's going to be pain sensations. The pain will be transmitted to the brain. The brain will see that as painful, and then the person will start crying. I don't want that to happen. So I want the person not to feel the pain. What can I do? I give an anesthetic, a general anesthetic. Okay. One example of such anesthetic is ketamine. Please have heard of ketamine before.
Yeah.
Yes,
Yes.
sir.
Yes.
If you give ketamine, how is ketamine able
Yes,
to
sir.
cause anesthesia? Ketamine will identify this receptor that we are talking about, okay, the figure E. And then it will identify where the glutamate binds to. Okay, see where glutamate is. It comes to bind to this area. That is where glutamate binds. Now, ketamine will come and bind to this area instead. Once it binds here, then glutamate can no longer bind. You need glutamate to bind so that you'll be able to process information, including pain. So now that glutamate is not binding because ketamine is there, it means that the person will not be able to now process pain. There's no neurotransmission again. That is why ketamine causes CNS depression. It binds to this portion, prevents glutamate from coming to bind. So long as glutamate does not bind, sodium does not go into the cell. Potassium does not come out. Once sodium is not going into the cell, there's no action potential generation. So there's no impulse transmission. There's no pain transmission. So essentially, whatever is happening in the body, the brain is not able to feel it. If glutamate is there, it opens the channel for sodium and potassium to flow in and then out so that impulses can be generated and transmitted. But ketamine will prevent that because it will prevent glutamate from binding to the receptor and then causing it to open to allow for sodium and then potassium to move. So in this case, this particular receptor, an example would be a receptor called NMDA receptor. NMDA is known as, or the full name is N-methyl D-aspartate receptor. That is the receptor that ketamine binds to. Any questions?
Ama wo ma ya behuhu ya bai ati ne so abedi ya ewo ya de ho a anwure ya ye bo mpa ye mo bo nte kai ye
Newscasters, yes,
We are
Remo.
not interested. We are not
Yes, Remo
interested.
pa.
Hey, Eradi, deliverance idiot.
Maybe after the class, you can probably maybe on your page discuss amongst yourselves so that you can. Else one day the things that we are going to hear,
Sir, we've
been
been communicating since day one. We don't even know their problem. Since day one, we don't even know their problem.
That's fine. That's fine. So yes, that is the ligand-gated ion channels. Okay. The first one is the
Sir,
NMDA receptor.
sir,
Yes, please.
please, the NMDA, you said the full name is what?
N-methyl D-aspartate receptor. All right. Now let's look at the second one. With the explanation I've given to you for the first one, the second one should be easy. Okay. All that you are trying to see is that for this particular receptor, it opens to allow potassium to go out of the cell. But then it will only open if the ligand calcium binds. Okay. So if there's no calcium, then that particular receptor is not going to open. But then so long as calcium is available in the body, it binds to the receptor, cause it to open so that potassium can flow out of the cell. Okay, so this is also an example of a ligand-gated ion channel. Specifically, we are going to call it the calcium-activated potassium channel. Okay. And then there's this third type of receptor. For this receptor, I'm going to mention it again when I'm talking about G protein coupled receptors, because what you need to activate this receptor will only be obtained following the activation of a G protein coupled receptor. It is when the ligand binds to a G protein coupled receptor that you can get the key to come and open this particular ion channel. Okay, but let's go through it again. If you look at it carefully, it looks just like the figure E. Okay, this figure looks just like this particular figure. All right, because both of them opens to allow sodium to go into the cell. That is sodium influx. And then they also allow potassium to flow out of the cell. That is potassium efflux. Okay, that is what both of them do. But then the difference is that the first one only opens for this to happen only when glutamate is binding. Okay, but then the second one that we are seeing here only open for sodium and potassium to move in and out only when another ligand is binding, but not glutamate. This ligand is known as a cyclic nucleotide. A cyclic nucleotide. An example of a cyclic nucleotide is cyclic AMP. Cyclic AMP is derived from ATP. It's called cyclic adenosine monophosphate. Another guy is cyclic guanosine monophosphate. So these are the two ligands there. Cyclic AMP, cyclic GMP. When they bind to the second target, then they can open it to allow for sodium to go into the cell, potassium to go out, so that they can be the generation of an action potential. Some of the drugs, a considerable amount that you be coming across in the hospitals, in the facilities, will have to be working on some of these targets, as you see very soon. Okay, so all these are ligand-gated ion channels. They will only open to allow certain ions to move either into the cell or out of the cell, only when a specific ligand is binding. For the first diagram, the ligand that is binding to it is glutamate. Glutamate is a neurotransmitter. Okay, when glutamate binds, the channel opens to allow sodium to move in, potassium. For the second diagram, okay, it's the ligand that is binding to the receptor to cause it to open for potassium to flow out is calcium. And then for the third one, the ligand that is binding to allow for the movement of these ions are the cyclic nucleotides. Over here, you have cyclic AMP. Okay, that is the ligand. And when we say a ligand-gated ion channel, basically, this is all that we are trying to see. There's a channel that allows for the movement of ion only when a specific ligand is interacting with that particular receptor. Ladies and gentlemen, any further question? Then maybe you can drop it here and move on to the next one some other time. Yes, Anastasia. Please, can you come again? I cannot hear you.
Hello.
Yes,
Hello, sir.
Anastasia. Yes, I'm listening.
I was asking that, does it mean that this type of channel, the ligand-gated channel, they are basically about the transmission of potassium from the intracellular out, and then the other gated ion allows itself inside? Is it only about potassium? Because you could see from the first diagram that the sodium neurotransmitter, the gated one, the first one, the E, is allowing potassium out through the glutamate channel, and then the F2 is doing the same thing. The calcium activated channel is allowing potassium out, and then the K2, the cyclical
Potassium is going
nucleotide.
out.
So yeah, so is it only about potassium?
Okay, so it is not only about potassium. I just needed it to illustrate my point to help you better understand. It could be any other specific ion at all. All that we are trying to say is that if you have a channel that allows for the movement of ions, then that particular channel is known as an ion channel. If that channel opens to allow for the movement of these ions, when a specific ligand such as glutamate or calcium or cyclic nucleotides are binding, a drug or a medicine is binding, then it's known as a ligand-gated ion channel. So this is just an example. Okay, it could be any other ion at all. Please, are you okay? Hello, please, are you fine?
Yes, yes, sir.
Okay, all right. Please, any other question?
Yes, sir. Please, you said the third ligand is cycling what?
Please, can you come again?
The third ligand. The first one is glutamine, the glutamine channel.
Yes, glutamate.
The second one is the calcium.
Calcium. The third one
And the
is the
third one is what?
cyclic nucleotide. So specifically, you have cyclic adenosine phosphate, then cyclic AMP. Okay, but then you can also get cyclic GMP binding. So they are known as the cyclic nucleotide, cyclic adenosine monophosphate, cyclic guanosine monophosphate. They are the cyclic nucleotides. Please, are you fine?
Yes, sir. Thank you.
You're welcome. Please, any other question? Then we
Sir.
can call it a sorry. Yes, please.
I want to call it a day. Sir, please, you see, during when a patient is taken to theater for, let's say, CS, first off, they will start with the spinal anesthesia. When it feels, sometimes they give dinner. So when the spinal anesthesia that has been given, for example, like the one you were saying, the ketamine, that is just within some short time, then it feels off. It's given and it doesn't work. And then another
But
drug
please, I
is given.
couldn't catch
What
the
happened?
last part.
Because the ion will go and bind itself.
I didn't get the last part of what you were saying.
You said?
I didn't get the last part.
I
So
was
when
saying that
ketamine is given and it doesn't work, then what happens?
I'm asking that when you give first anesthesia and it fails, and then you change the drug to another anesthetic drug, what happens to the body? Because already you have introduced one a channel blocker, and you are introducing another one. What happens?
Okay, all right. So later on, we are going to do anesthesia. We are going to talk of CNS depressants and CNS stimulants. And we'll talk more about this. Okay. There's more that goes into choosing a general anesthetic for a patient. And sometimes you may use a specific general anesthetic and it's going to fail. Sometimes it's because of the technique. Other times it's also because of the patient that you're having. All right. Sometimes some past medical history can interfere with it. Some enzyme levels that the individual is having can also interfere with it. So there's a lot that goes into choosing a drug for anesthesia when it comes to that. Okay. But what I can tell you about the duration of action for these things is that when you have a drug that works on an ion channel, you later get to know that they are able to cause the effect rapidly. So within a short period of time, realize that you begin to see the effect from the drug, but then it does not last. Okay, it does not like it wears off easily. So when it happens as such, you may have to replace either give the drug oftentimes, which is dangerous because it can accumulate, the metabolites can accumulate and cause a lot of harm. Or when you use it to induce the anesthesia, then you can use other drugs that works on other means or work by other means to maintain the anesthesia. So in this case, you choose one that does not depend on or that does not work on ligand-gated ion channels. Okay, so basically that's what I would say. The ion channels are able to give rapid onset of action, but then the duration of action is also very, very short. So sometimes you may have to maintain anesthesia using another technique. Please, are you okay? We talk more when you are discussing general anesthesia.
Okay.
Thank you, sir.
Right. You're welcome. Please, any other question?
No, please.
Okay. If there are no other questions, then it's already 8. Unless you want me to continue, then I'll continue. Maybe we can take a beat, go back and rest and then relax. Then look at the notes again. Okay. I'm not going to